Good evening, everybody, and welcome to Together Facing Head and Neck Cancer. Thank you to our patients, our caregivers, our patient advocates, and all of our guests for joining me and our team here tonight. I'm Dr. Jessica Bauman. I'm the Chief of the Division of Head and Neck Medical Oncology. Tonight, my colleagues and I look forward to sharing with you the latest research and treatment developments for head and neck cancer. Although we wish we could be doing this in person, of course, we hope that you find this program inspiring and informative from wherever you are joining us tonight. If you are watching this and have a Facebook account, we encourage you to ask questions in the comments, and we will answer you later in the evening when we have a chance to do a panel questions at the end. At our Together Facing events at Fox Chase, we always begin with honoring those that we have lost to cancer. So please join me now in a moment of silence. Thank you. I'd also like to take a moment for our exhibitors for this evening. It's because of their generous support that we can offer this free program to you tonight. So a special thanks to our gold exhibitors, Karis and Tempest, as well as our silver exhibitors, Eisai, Galera, Lilly Oncology, Myra GTX, Natera, Sanofi Genzyme, and Stryker. And a special thank you to SPUNK, which is an acronym that stands for Support for People with Oral and Head and Neck Cancers, for their support and partnership in the community. As you see, we have several people here from our multidisciplinary team, and I will introduce our panel for the evening. Each of our panelists will take a few minutes to introduce themselves and discuss their area of expertise. One of the best parts for me about working at Fox Chase is the exceptional multidisciplinary approach we have to patient care that incorporates all specialties: surgery, radiation, medical oncology, endocrinology, speech, rehabilitation, nutrition, social work, and other supportive care services to obtain the best short and long-term outcomes for our patients to preserve quality of life and function. Today, we have invited a representative from each part of our team to speak about different aspects of head and neck cancer and advances and treatment. To start tonight's panel and discussion, I will introduce Dr. Jeff Liu.
Thank you very much, Dr. Bauman. Hello, everybody. My name is Dr. Jeffrey Liu. I'm a head and neck cancer surgeon here at Fox Chase Cancer Center, and I'm also faculty at the Lewis Katz School of Medicine. And this is my almost 10th year here at Fox Chase taking care of patients, which has been a wonderful privilege. As a surgeon, my interest is in bringing surgery toward the care of our cancer patients, but it's not just about doing the surgery and taking care of the problem, but really working with the entire team, many of the members who you see here, and trying to develop a plan that works for each patient's cancer. Every cancer is unique. Sometimes there's similarities between patients and sometimes there's differences between patients. And how we treat each and every cancer is both very individualized to the specific cancer, but also follows best guidelines for cancer stage and cancer type. And I'm privileged to work with this group. We spend a lot of time talking about our patients to try to figure out the best plans for patients. And as you will see, as you meet other people in the group today, not only are we interested in achieving the best possibility for cure for each patient, but also returning them to where they came from before they got cancer. So we haven't really been successful if we cure the cancer, but patients are left completely unable to rejoin the life that they love. If they can't spend time with their family effectively, if they have difficulty with communication, if they can't go back to their jobs. And one of the things that's very unique and special about head and neck cancer is that it affects so many things: eating, drinking, swallowing, talking, how you look and how you appear and how you communicate. And so here at Fox Chase, our team is not only here about taking care of your cancer, but also getting you back to the life as best as we can to where you were before you were diagnosed with cancer. I do have a specific interest. My clinical interest is in head and neck cancer as it relates to cancers that arise from the skin in the back of the throat, squamous cell carcinomas, and specifically racial disparities in that cancer. Having worked both at Fox Chase and actually Temple main campus down in North Philadelphia for almost 10 years, I'm part of a team that is doing research to understand why some patients get cancer and some patients don't. And without going too much into it, because if you ask me about my research, I'll talk all day. In short, we've come to understand that there are ways that people's bodies in general between blacks and whites, but also some of the detailed genetic signatures of patients individually can kind of predict whether or not they respond to treatment or not. And so understanding what are those signatures and how we can use them is the first step toward picking the right treatment for patients every time. And so this is a space that I've been working in for a number of years. We're very excited. We are funded by the National Institutes of Health and has been a longstanding interest of mine. So I look forward to hearing from my colleagues, and thank you for joining us today.
Next up is going to be Dr. Christopher Yao, who is also a member of the Department of Surgery.
Good evening, everyone. I'm Dr. Christopher Yao, and I just recently started here at Fox Chase Cancer Center. I'm very, very proud that I work here, and I'm delighted to work with some of the most intelligent and dedicated specialists I've ever worked with. I love that we all share the same passion and care for head and neck cancer patients, and that we all think about the patients every single day. As a surgeon, my role is integral to any patient who has head and neck cancer, whether the treatment involves surgery or not. Oftentimes, as these cancers occur in an area with a lot of complex anatomy, I may play a role in the diagnosis or prognostication of these cancers. However, a lot of times, surgery does remain to be the mainstay of treatment. Similar to Dr. Liu, I believe each and every patient is unique. With surgery, new techniques have allowed us to tailor surgical approaches as much as possible. My goal with surgery is to take out the cancer in as minimally invasive way as possible while respecting oncologic principles. This may involve using the robot or sometimes other endoscopic instruments. Furthermore, a large part of my practice is in reconstructive surgery. With this type of surgery, my goal is to restore patients' form and function. This often involves moving tissue from somewhere else in the body towards where the defect has been created, or it might be just moving tissue from around the area. More and more, I've been also performing some nerve reconstructive techniques that help aid patients in their rehabilitation. However, every patient is very different and the reconstructive needs vary tremendously. So based on a patient's body, I would choose locations where I think taking tissue from would lead to the best long-term function and with minimal morbidity. Like all my colleagues, I'm very invested in each and every patient I see and follow them closely through their cancer journey. What brings me a lot of joy, however, is seeing survivors of head and neck cancer. It is always reinvigorating to see those who have come out and have been able to find their quality of life and find what brings them joy again. And so this does lend to some of my research interests to optimize the long-term survival outcomes and survivorship issues. But it's why I am so thrilled to be part of the Fox Chase Cancer team.
So we're going to transition to me speaking briefly about some of the new advances in medical oncology. As you know, I'm Jessica Bauman. I'm the Chief of Head and Neck Medical Oncology here at Fox Chase. And Dr. Anshu Giri and I are going to discuss the advances that we have seen in particular in recent years. As medical oncologists, we use systemic treatments, which means chemotherapy, immunotherapy, or targeted therapies to help cure or control head and neck cancer, depending on the specific scenario we are facing with each individual patient. Excitingly, we are starting to see advances in new therapies such as immunotherapy and targeted therapies in particular in recent years. One of the major changes we have seen in the last decade is the advances of the understanding of what's going on at the molecular and DNA level of head and neck cancer and in thyroid cancer. When someone has a diagnosis of advanced disease, we now send molecular testing on everyone, on all of their tumors specifically, to determine whether there are changes that will open a door to some kind of targeted treatment. This has been very successful in other cancer types. However, it's in some ways just beginning in head and neck cancer. And though it's also been something that we've seen more commonly in thyroid cancer in recent years. One example of this is a drug called tipifarnib, which is not yet FDA approved, but we participated in a recent trial that shows significant benefit for patients with this drug when they have a mutation called an HRAS mutation, which is present in about 2 to 5% of head and neck cancer. Tipifarnib has now actually received breakthrough therapy designation from the FDA and remains in investigational trials. And it's through all of this new work that has been done that we've been able to identify patients, such as patients who may benefit from these more targeted therapies. Another example, several examples, are in thyroid cancer, where we've actually seen 2 approvals in this past year for drugs that target RET mutations or fusions, which are pralsetinib and selpercatinib. And these can be found in medullary thyroid cancer as well as papillary thyroid cancer. What is exciting about these targeted drugs is that they're more specific to a patient's tumor and often have fewer toxicities. And it really is in recent years that we're finding more and more of these potential targets in various types of cancers that allow us to do more what we would call precision medicine for our patients. And it really has maximized our ability to treat patients more effectively. So we're excited to be able to offer many of these types of clinical trials, as well as new molecular testing techniques with new possible treatments to our patients here at Fox Chase. With that, I'm going to transition over to Dr. Anshu Giri, who's also a medical oncologist, who's going to talk a little bit more about immunotherapy and the advances.
Thank you, Dr. Bauman. As was just mentioned, my name is Anshu Giri, and I'm also one of the medical oncologists at Fox Chase that focuses on head and neck cancers. I've been here for approaching 2 years now, so still relatively new, but definitely been around for a little bit now. So we just heard about the new and exciting targeted therapies for head and neck cancers. So as mentioned, I'm going to transition briefly to a different type of new treatment modality, which is immunotherapy, also known as checkpoint inhibitors. And at this point, I'm sure many of us have heard of immunotherapy. There's in fact a new commercial on TV, seems like every other day at this point. But rightfully so, these are very exciting treatments, and they have been approved in many different types of cancers at this point, including head and neck cancers. In fact, for advanced head and neck cancers, immunotherapy has become the standard of care in certain situations, not all situations, but in certain situations that is now first line standard of care. And just briefly about how these treatments work. So cancer cells, for whatever reason, develop a way to hide from the immune system. And by doing so, the immune system just can't see them, and it allows these cancer cells to grow and proliferate. One of the ways they do this is through the PD-1 pathway, and many of these checkpoint inhibitors, at least the ones that are approved so far, interfere with this pathway. And by doing so, it allows the immune system to see these cancer cells again and hopefully get rid of them and clear them from the body in a natural way. Some of the benefits of immunotherapy compared to some of the other systemic treatments that we use, specifically chemotherapy, is they tend to be less toxic. That's traditional chemotherapy does have its set of side effects, and most people agree that immunotherapy is much better tolerated. There's, of course, always going to be certain side effects to any treatment that we give, some serious side effects, of course, as well, but in general, it's better tolerated than traditional chemotherapy. And while these treatments do seem to work in a lot of our patients, unfortunately, they don't work in all of our patients. So I think a lot of the research that's ongoing for checkpoint inhibitors is looking into how to make them work better. Some of the trials that we've had open recently are trying to combine 2 different types of checkpoint inhibitors. So maybe do the PD-1 pathway plus a whole other, many different types of checkpoints out there that we can potentially target. And then just combining checkpoint inhibitors with different type of treatments altogether. So chemotherapy or other types of monoclonal antibodies as well. And the other thing that immunotherapy is starting to get into is how to use it in the earlier stages of head and neck cancer. So We're looking into, can we use these in some of the good risk, early stage, good prognosis head and neck cancers? Maybe substituting chemotherapy for some of these immunotherapies. And this is still investigational, but that's something we're trying to do to maybe avoid some of the toxicities of chemotherapy. And we do have many of these immunotherapy clinical trials open at Fox Chase. And we're really, really excited to enroll patients on these trials because it's such a promising new field.
Thank you, Dr. Geary. Dr. Tom Galloway, the Chief of Division of Head and Neck Radiation Oncology.
Thank you, Dr. Baumann. Hi, everyone who's out there, wherever you are. My name's Dr. Tom Galloway. I'm a radiation oncologist at Fox Chase Cancer Center. I specialize in the treatment of what we call head and neck cancer, mouth, throat, and neck cancer, and skin cancer. For all of you that are watching with us live right now, I'd like to thank you for choosing to spend part of your Wednesday evening with us. I think I'm not alone with saying I'd love it if we could do this in person and I could see all your faces. Also, like how I'd love to see my patients without a mask on, and I know we'll get there soon. But I still like being able to spend this time with everyone. Head and neck radiation can be used two primary ways, either after an operation, after appropriate time for an operation, when the results of the operation seem to suggest that additional therapy is necessary. That is a situation where we give radiation after the operation, or sometimes we give radiation in lieu of an operation as what we would call the definitive therapy in that setting. So it's either given as primary definitive therapy or therapy after an operation. Sometimes the decision-making process for is this radiation after surgery or before surgery is very simple and plain. And sometimes it's nuanced and it takes a lot of conversations like we're having right here, where I'm staring at the faces of surgeons and reconstructive surgeons and medical oncologists and social workers and speech therapists to make the right decisions for patients. And so that is how a lot of patients with head and neck cancer end up meeting with a radiation oncologist, sometimes at the initial diagnosis. In terms of what's new for radiation, radiation for too long has been a broad brush. We typically prescribe a set group of regimens for all patients, and we really don't have the opportunity to personalize, or we haven't in the past had the opportunity to personalize. And as we have become more developed and more sophisticated in what we're doing, our ability to hopefully pre-treatment identify ways to personalize therapy is something that all of us are looking forward to as radiation oncologists. And there are studies that we're running at Fox Chase that test both of these principles. Identification of good prognosis patients for whom we actually look to give a slight bit less treatment and still identify the same high cure rate. And I will assure you, I could give an hour lecture of why even a 1 week decrease of radiation could be expected to deliver an exponential decrease in normal tissue toxicity. But that's for another lecture at a different time. Similarly, identifying patients for whom actually intensification is necessary, for whom patients we didn't intensify traditionally, in terms of looking at the molecular signature of some of these tumors, as Dr. Baumann and Dr. Geary referred to earlier. But I guess I would say, even for patients who don't go on a clinical study, radiation is a big data field. We generate these huge amounts of computer-generated data with regards to how our treatment plans are developed. And as a consequence, our treatment plans are constantly being massaged and manipulated. And I will say a treatment plan that a radiation oncologist does is a continuing evolution. And so as we identify better ways to mold and scope and sculpt the radiation dose, there's advances in the field of hopefully curing cancer at the same high rate and limiting long-term toxicity. And so radiation that I am practicing now is different than what I did 10 years ago, and it'll be different 10 years from now. And as someone who's interested in academic medicine and promoting both cure and survivorship, it's a really exciting time to be involved in head and neck cancer.
Great, thank you, Dr. Galloway. Leanne McCarroll, she is joining us as a senior speech pathologist tonight.
Thank you, Dr. Bauman. I would like to echo the sentiments of my colleagues. I'm honored to be here tonight to talk with everybody. I wish we could be in person, but maybe next year. So as Dr. Bauman mentioned, I'm a senior speech pathologist here at Fox Chase Cancer Center, and I'm also an assistant research professor. An aspect of care at Fox Chase that makes us unique is that when someone receives a diagnosis of head and neck cancer, they're given the opportunity here to work with an academic speech pathologist really across the continuum of their cancer care journey. This starts at the time of diagnosis and continues throughout survivorship. I was very happy to see pictures of some patients or survivors in the early part of the presentation that I've known for as long as I've been here, 8 years. So we really do work with our patients long term. Another unique aspect is that our physicians really do advocate for our involvement and encourage the patients to work with us from the very beginning. This is considered best practice, as both head and neck cancer itself and its associated treatments are known to cause both short-term and potential long-term dysfunctions to both speech and swallowing. So our services include advanced evaluation and treatment tools for dysphagia, which would be difficulty swallowing, for trismus, which would be reduced mouth opening, dysphonia, difficulty voicing, and speech or oral motor dysfunctions. So the structures in the mouth that we use for speaking, the tongue, for example. We are able to provide detailed assessments of swallowing through objective measures. Our speech pathologists can complete video fluoroscopic swallowing evaluations, where is when we can actually watch your swallow under an x-ray, so we can see exactly how things are functioning internally. And an alternative to that is a flexible endoscopic evaluation of swallowing, where we watch you swallow, we place a scope through the nose and into the throat, and we actually watch through the camera. Some assessment options that we have for voicing, we can complete stroboscopy, which is a detailed exam of the voice box. Again, we use a scope, and this is connected to a camera with a lens, and it has a pulsing or a strobe light, and it really gives us detailed information about how the voice box is functioning. And this helps us give better treatment. So our team of speech pathologists, we have specialized training in head and neck cancer rehabilitation, and we work with our patients to evaluate the current level of speech and swallowing function, at diagnosis, provide education of what changes they may experience both during and after treatment. And then we develop a personalized therapy plan in hopes of maximizing long-term functional outcomes, because we really want to do everything we can to get patients back to kind of their pre-cancer function when possible.
Thank you so much, Leanne. Karen Vinchek, our nutritionist or dietitian.
Hello, everyone. Thank you so much, Dr. Bauman. As Dr. Bauman said, my name is Karen. I'm one of the dietitians here at Fox Chase. I'm so grateful to be part of this event tonight because I work very closely with many of our head and neck patients here at Fox Chase. So many times I've noticed when I first meet with a patient, they are kind of surprised that they're going to be working with a dietitian. And some of the questions that might come up frequently are, what exactly is a dietitian and why will the dietitian be involved in my care? So I wanted to start off by briefly answering those questions because I think they're so important. First off, to explain what a dietitian is. A dietitian is a licensed and board certified expert in the area of food and nutrition. And a dietitian goes through extensive training on various medical conditions and the nutritional guidelines that go along with those conditions. And I think that that's so important to mention tonight because we have so many people out in our communities, on the internet, and just in different places that are dishing out nutrition advice, but unfortunately not everyone is qualified to do that. And we really should be careful with where we're getting our health and nutrition information from. And to move on to the other question as to why the dietitian forms part of the care team here at Fox Chase, that's because research has shown that if a person is able to eat well or as best as possible as they go throughout treatment, their outcomes are just exceptionally better. Eating well and staying well hydrated can help in so many different ways. It can help so that a person tolerates their treatment better. It can help to prevent any delays or breaks in treatment. It can help to prevent any unplanned hospitalizations, or maybe even make it so that a hospitalization could be even shorter. It can really help, it can contribute to a person's overall quality of life. So these are all, of course, very significant things, but the reality is that eating well for someone who's been touched by head and neck cancer can be so challenging sometimes. We know that barriers are likely to arise when it comes to eating. And it's because of these barriers that one thing that we very frequently see is weight loss. Whether or not a person might have the desire to lose a couple of pounds, we always talk about the importance of not pursuing this anytime around treatment. So as you work with a dietitian here at Fox Chase, one major focus really does become holding on to your weight and your muscle mass as much as possible and for as long as possible, because again, this is another thing that has been shown to contribute to a person's outcomes when it comes to treatments. So another focus as you work with a dietitian here at Fox Chase is just helping you, navigate through the possible complications that could arise with eating. So for example, if someone were to have difficulties with mouth pain or mouth sores or taste changes, the dietitian really helps to work closely with a patient to give them nutrition advice as to what would be better tolerated, but still very nourishing when you're faced with some of those challenges. So before I pass along the baton to my next colleague, I just wanted to close by saying that nutrition counseling services are available for all Fox Chase Cancer Center patients. And these consultations, these nutrition consultations, they're totally free of charge. They were always held in person, but since the pandemic, we now have the option of also holding consultations over the phone. And I'm really grateful for that because I know that that has been something really valuable for a lot of patients and their caregivers. So we're going to be sharing the phone number that you would call to schedule an appointment for that later on this evening. And I just wanted to close by saying thanks to everyone for giving your attention tonight. And I look forward to any questions at the end.
Great. Thank you so much, Karen. Pankaj Sharda, who is the director of our thyroid program, will be speaking next.
Hi, good evening, everybody. My name is Pankaj Sharda, and I direct the thyroid program at Fox Chase Cancer Center, where it has been an amazing journey for me working in a very multidisciplinary fashion with my team, and especially more working with my patients. And coming back to what our topic is today is facing head and neck cancer together. And that's where, as an endocrinology, where my focus has been is engaging our patients to be involved in their patient care. That has been one of the key things I always focus on. My focus of practice has predominantly been thyroid nodules and thyroid cancer, which is very prevalent, what we see in our practice. And more so is to provide individualized evidence-based care rather than a cookie cutter approach. And that's where has been a major shift in the thyroid cancer care, where it was more of everyone gets the total thyroid out, radioactive iodine, and massive doses of thyroid medicine, to a more tailored approach, depending on the type of cancer, the aggressiveness, and so forth. One of the key things, again, which I really focus at Fox Chase is to engage the patients in that decision-making. So that because this is a long-term care, and I always am a firm believer as we as physicians and our patients learn more, we can achieve more. And that's always I really count on. And for me, taking care of patients is like clapping. You need two hands. I cannot clap with one hand. So engaging my patient in my patient care helped me deliver better quality and better evidence-based care. I'll keep it short because we want to make sure that we have enough time for questions, and I'll turn it back to Jessica. Thank you so much. Thank you.
Thank you, Dr. Sharda. And last but not least is Florence Bender, our social worker extraordinaire.
Thank you, Jessica. And to the rest of the group, I thank you all for your wonderful input. And as I'm going to introduce myself as the social worker for the head and neck team. I couldn't do it without the rest of you. And I think that for the people who are joining us this evening, I hope that you can see that you have an extraordinary group of people who have tuned in to help us with this evening. As a social worker, I can tell you that this is a very tough subject, as you can hear. And the reason that there's a social worker on the team is that I can help keep you all together. As a social worker, the role that I play is truly just that. I am here to provide the emotional support to you and your family. And as the social worker, I can do a lot of other things. We can help you with your finances, the insurance. Right before this program took place, one of the surgeons and I sat with a family and did just that, trying to help them put some decisions in place as to how they were going to have a treatment plan. And it really does take a whole team. And we have all worked together to do that. So we hope that you will hear all of our pieces this evening, and we will gladly kind of, share with you all those pieces of information. You heard from physicians, nutritionists, other members of the team. As you heard from Leanne, we work closely together from the beginning of the diagnosis throughout the continuum and into survivorship. It's kind of our roles together from the start, social work and speech. We kind of oftentimes are the first two people to meet some of these patients and their families and kind of help organize and get them started on their journey. So we will certainly be there to kind of help you together, and we'll try to answer whatever questions might come along.
Great. Thank you so much, Florence. And Florence has been here for many years and is the leader and the creator of the head and neck support group here at Fox Chase. And we are incredibly lucky to have had her intelligence and support and insight into the patient's care, into our patient's care for so many years. We are now going to transition to open it up to the audience for questions. So please feel free to drop a question in the chat function on Facebook. And if we don't get to your question this evening for some reason, we will be following up after the event concludes. So we will certainly try to get back to everyone with any questions that you have. So please feel free to send questions our way. And they're being sent to me live stream. So the first question from our audience is, what are the potential long-term side effects from radiation for head and neck cancer? What are the potential long-term side effects for patients with head and neck cancer? And is question number one. And is there anything that you do at Fox Chase in particular to help prevent those side effects? Dr. Galloway, I think that we can give this question to you.
So, I'll speak first, and I think it'd probably be best if Leanne also spent some time talking about this. The thing with long-term toxicity is that it's an amazingly complex process. I'm sure a speech therapist should probably say this rather than I. It's an amazingly complex process to get food from here to here. There's a huge amount of very small muscles and very small processes that need to happen in a coordinated manner to allow this to happen safely. And so when we are delivering therapies to destroy things that are growing in that area, whether it be by removing it with a scalpel or by treating it with radiation, it causes these consequences of function. And we have for decades as radiation oncologists known that we've had patients who tolerate therapy well, do well, and then something happens sometimes many years down the road. And we have published about this, and we go on podiums nationwide to talk about how this is an important thing, that you should not be discharging your patients because things can happen after that discharge happens. And it's an important thing to be mindful of as a treatment team that takes care of this part of the body. What are we doing to try to prevent those long-term toxicities? Well, I think some trends are helping us those long-term toxicities independent of their specific avoidance. Radiation and surgery have both become more targeted, less broad brush, more personalized. And so we are hopeful that the toxicities we're seeing from patients treated in 2000 are not going to be present for the patients treated in 2020 because they were treated in a way that is so different. The treatments almost don't resemble each other. Also, in just the 11 years I've been at Fox Chase, there's been a much better integration of rehabilitation into the treatment of head and neck cancer, to where the patient sees speech therapy before, sees speech therapy afterwards. And when they do that, they're instructed on really how to keep function as maintained as possible during treatment, with the idea that if we do that during treatment, it'll increase our chances of doing it right after treatment, increase our chances of doing it at 1 year, increase our chance of doing it 2 years, increase our chance of doing our exercises for a lifetime. And so those of my patients that are listening have probably heard me say, you brush your teeth every day, you comb your hair every day, I need you to do your exercises every day. And so I think the two main ways of preventing these long-term toxicities are for the treatment team to be mindful of it on the treatment side and make our treatment as targeted as possible. And then also to integrate rehabilitative services early and often during treatment to help with maintaining that function. And this is a research interest of mine. I petitioned a NCI group to get a big data bank to look at what's predicting long-term toxicity. I thought it was going to be intensity of chemotherapy. I thought it was going to be intensity of radiation. And actually, neither of those came out as an indicator of long-term toxicity. The biggest indicator of long-term toxicity was extent of tumor at diagnosis. So I would say also, if you have a family member, or if you have a neighbor or your Uber driver that has a bump in their neck, recommend they get it checked out. If there's one thing we're learning, it's the chance of long-term toxicity is much less for smaller tumors that can be managed with much more targeted type treatment than larger tumors. Leanne, did I steal your thunder? Did I talk too much?
No, Tom, you talked just the right amount. But I agree, getting the speech pathologist, getting rehab involved early is key. A big factor for helping someone understand what their long-term function outcomes might be is having good information about their baseline function, and getting that information before treatment starts is really key to that, and encouraging our patients throughout treatment to eat, and as Karen mentioned, we want them eating healthy food, nutritious food, staying hydrated, but eat and exercise. We promote, and when I say exercise, physical exercise is good, but that's not the exercise we mean here. We mean targeted exercises for mouth opening, for tongue mobility, and for all those muscles inside the throat that we use for swallowing. Eat and exercise throughout treatment. We encourage our patients to keep exercising those structures long term in hopes of maintaining maximal functional outcomes. and its survivorship and quality of life related to swallowing is a research interest of mine as well. And, we're actively looking at, how do our patients do long-term? How are survivors, their function long-term? And then, adherence to exercises. What is the right number of exercises for someone to do, and for how long they need to do those exercises to really have the best outcomes. So those are all things that we are actively looking into and researching.
Thanks, Leanne and Tom. I'll go to another question, which is from the audience, which is, are there any tips you can offer patients who are experiencing decreased appetite due to pain and discomfort from treatment? And I'd love to hear from both Dr. Geary and Karen about this one.
So really good question, because of course this is an issue that is very likely to occur. I usually tell patients, I wish that there was something, nutritionally that I could recommend that could help with lessening pain and just make it easier to eat. But, food-wise, we don't have that possibility. However, there are certainly more foods that could be more comfortable if a person is having mouth pain. I often talk about foods that are soft textured. And honestly, the foods that we would traditionally consider as probably kind of a little bit boring or bland, like things like cream of wheat or oatmeal, end up becoming really valuable as a person goes throughout treatment, because these are foods that are pretty nourishing. I always say they can be doctored up in different ways. There's different ways we can add lots of calories and protein and overall lots more nutrients to really soft and bland foods. And those foods end up becoming very comfortable. And another thing is that when you're experiencing pain with eating, obviously you're no longer enjoying the process of eating. And so many times people will say that turns eating into feeling like a chore. And if that is the case, if you're not enjoying eating, instead of, trying to follow the typical pattern where we get ourselves to have a nice big platter at breakfast and lunch and dinner, shrinking those meals, having smaller amounts of food, but on a more frequent basis can make, the job of eating a little bit less, of a job. So you can basically just kind of take smaller amounts of food and you get over it a little bit quicker. It's a little bit easier.
Thank you, Karen. Dr. Geary.
That was a really good way to think about it, is, the types of food you're eating and how to kind of get the smaller meals. And I think the other big aspect of this is pain control itself. So if you're going through some of the treatments that we administer, whether that's chemotherapy with or without radiation, sometimes there can be some element of irritation in the mouth and throat. And, I think we try to do a pretty good job of controlling that pain, which can really help with someone's ability to eat. Some of the things that we've been doing is using medications such as something called Gabapentin, which is when people are going through these treatments, sometimes we use that to minimize some of the neuropathic and mucositis and irritation of mucous membranes that we sometimes cause. And by doing so, that allows patients to actually be able to eat without the discomfort. We also have mouth rinses that we recommend to help with the irritation in the mouth. We also have something called magic mouthwash, which some people love. And it's a type of medication and solution really of lidocaine, Benadryl, Maalox that you kind of swish around in your mouth, and it helps numb up the areas in your mouth and helps make swallowing a lot easier. And a lot of those things we actually recommend to do, right before a meal. Like do magic mouthwash 10, 15, 20 minutes before a meal, then your mouth will be nice and numbed up, and it definitely makes it a lot easier to eat at that point. And then, at the end of the day, we always have our very strong pain medications, which are a big part of, unfortunately, what we do. And, the opiate pain medications, oxycodone being a very common one. We do sometimes have to use those when the pain is very difficult and bad. And same idea, you have to control the pain to make eating easier, and taking an oxycodone 30 minutes before a meal can sometimes really, really help. So those are the things I usually advise my patients to do, along with exactly what Karen said. And we also send our patients to our wonderful nutritionists to help kind of reinforce those things as well.
Great. Thank you, Karen and Anshu. Next question is, how many new cases of head and neck cancer are there every year? Is that number going up? Dr. Liu, would you like to take that question?
If I can get the numbers off the top of my head, I think it's about, depending on how you measure. So remember, head and neck cancer is a group of diseases, which include thyroid cancer, salivary gland cancers, and also mucosal cancers, are cancers that arise from the skin in the back of the throat, which are broken down to tongue, base of tongue, or voice, tonsils and larynx. And if I have my numbers right, I think the number of new cancer patients is about 60,000 total, if that sounds about right. I see other colleagues nodding their head, but I'm very glad I got that number right. And then new thyroid cancers is something about, I think, 45 or 50,000 cancers. So although thyroid cancer is, and thank you, Dr. Sharda, for nodding your head over there. I know I'm speaking accurately when my colleagues are agreeing with me. So that is the number of new cancers that happen a year. And there was a second part of that question, Jessica.
And is the number going up?
Yeah, that's actually a very interesting question. So as it relates to, let me talk about thyroid cancer and then squamous cell carcinoma cancer separately. So thyroid cancer numbers are going up, but there's an entire body of literature that demonstrates that though the number is increasing, fortunately, it doesn't mean that more people are dying. So you would think that if we found more cancers, then, as that number went up, then the number of people as a percentage would be dying. But it turns out that with thyroid cancer, lots of people actually are walking around with thyroid cancer and don't even know it. And one of the things that's difficult about thyroid cancer is that sometimes thyroid cancers can just hang around and not really progress. And so as it relates to thyroid cancers, the numbers are going up because so many patients get CAT scans or ultrasounds for things unrelated to their thyroid. Like, let's say you get into a car accident and they get a CAT scan of your neck because you hurt your neck and say, oh, your neck is fine, but there's a thyroid nodule, and it turns out after workup that's thyroid cancer. It turns out not all those thyroid cancers would have been something that would have caused you illness necessarily, but we don't know which ones to pick out of the hat. So thyroid cancer numbers are going up, but fortunately that has to do with increased detection, not because it's a disease that's necessarily getting worse in our population. As it relates to squamous cell carcinoma, fortunately, we may all be out of the job in a couple of years because less people are drinking and smoking. And so that means that the number of head and neck cancers in general has been going down for a number of years. And that's a good thing as people live more healthy lifestyles. There's less of one kind of cancer. We're very happy to say that. But don't hold your breath too soon, because it turns out that some other types of cancer are going up in the head and neck, and specifically oral pharynx cancer, which is cancers that arise from the tonsil and base of tongue. So since about the early 2000s and really recognized well after 2010, the same cancers that we see, which is called squamous cell carcinoma, while being caused by alcohol and tobacco, have gone down due to lower usage in our population, the cause from the human papillomavirus associated cancer or virus associated cancer in non-smokers and non-drinkers has actually continued to go up significantly. So there's an epidemic of this cancer that's on the rise. The good news is that most of these patients do better than their drinking and smoking by comparison, but this is still a cancer that's on the rise that we still don't exactly understand who gets it and why, and it's an active area of research. So to answer your question, thyroid cancers are going up, but it's only because we're finding them, not because we have an epidemic of the disease necessarily. And for squamous cell carcinoma, drinking, smoking-related cancers are generally on the way down, which is good because people are being healthier, but virus-associated cancers, specifically associated with the human papillomavirus, are going up.
Thanks, Dr. Liu. Next question is, do you recommend patients to see their dentist or dental hygienist prior to treatment? And on top of that question, is there any chance that Fox Chase will add dental professionals to the head and neck team, as it can be hard to find providers? Dr. Galloway, you're definitely taking this one.
So I'm chuckling because this question seems like it's a plant. I mean, I have been grumbling for 11 years of my desire to have a dentist that could be down the hall for me. Where I trained, we had that. And I will tell you, for the first 3 years I was at Fox Chase, I would call her regularly and ask her about dental questions because I found it so useful to have someone like that. And, the structural problem of the dental school is, I don't know how many miles away, TUHs from Fox Chase, but the structural problem of the dental school is not on the same campus as we are, is a barrier to that. And whoever asked this question, I'm going to keep fighting for this because it is something that I want and I think would be better for our patients, but we do not have a short-term plan to enact this as of right now. Do I recommend patients see a dentist before treatment? Absolutely. In certain patients where there is needed dental work that can be seen in the mouth, that's fairly clear. Yes, that patient, because the radiation will complicate the dental remediation that would need to happen afterwards, it is beneficial to have that patient see a dentist before treatment. But even in the patient who has exemplary dental health, exemplary oral hygiene before radiation begins, radiation changes the environment of the mouth. It makes it drier, and a dry mouth is, again, my patients that are on this will be familiar with these words I use. It makes it a petri dish for bacteria, and bacteria will cause cavities, and cavities in a dry mouth accelerate faster than cavities otherwise. So I think it's useful that I go over this in detail with my patients, as do my residents and my nurse. But I think it's also useful for patients to hear this from their dentist, who they've probably known longer than me at that point, in terms of, you need to be diligent about oral hygiene after having had neck cancer. And so I think that even in the patient who brushes 3 times a day, flosses, uses a water pick at diagnosis, does everything their dentist would ever hope, I still think that patient seeing a dentist before treatment is a very good use of time and a very good practice pattern. But we're going to work on getting that dentist at Fox Chase.
Thanks, Dr. Galloway. Next question is, does Fox Chase have a head and neck cancer support group? Florence, I'm going to have you take this one.
Yes, Dr. Baumann, and to the persons who asked that question, we do have a support group, and Leanne and I we have, right now it's virtual, but it has met in person for many years, and we kind of started it. At the present time, one of our other speech pathologists and I co-facilitate the group, along with a nurse, so that we meet once a month, and it's kind of changes, but it's usually on the 3rd Wednesday from 12. It's always from 12 to 1. So all we have to do is kind of check in with the speech department or myself, and we will make sure that anybody and their family can join.
And Florence, can you comment, do you have to be a Fox Chase cancer patient
No,
too?
anybody in the community is welcome to join the group. Do
I
not,
think that's a very important thing to point out, that
anybody in the community is, anybody who's on tonight or wants to notify a family member who might be changing, it's open to the community.
I think it's really important because, as you know, there are many excellent centers, but this group is really focused on being access for our local community here in the greater Philadelphia area. So we welcome all comers. You don't have to be a Fox Chase cancer patient to come.
Absolutely do not. And it's been in existence for a number of years.
And now that it's virtual, because we meet over Zoom for our support groups, we've had people that live out of state that attend. So anyone that's watching that's interested, the information is on the website, but the organizers, especially the person that asked the question, we just need the person who's interested in attending. I just need their email address, and we invite you to attend the meeting. So we can help facilitate that, I'm sure, in the background after, if anyone is interested.
Great. Thank you, Leanne and Florence. One more question is, do you have many patients many, many years out from thyroid cancer who also had radioactive iodine that end up with some kind of secondary cancer? Dr. Sharda, I'll turn this one to you.
Yes, no, thank you. Thank you, Dr. Bowman, for that question. So very, it's an excellent question. So traditionally, the thyroid cancer treatment has been 3 steps, right? Surgery, radioactive iodine, and TSH suppression. And again, traditionally, there has been an excessive use of radioactive iodine where everybody got a lot, like 100, 200 millicuries, right? And that pendulum again has shifted towards using lesser radioactive iodine treatment, which I see is kind of a theme of our talk today, where every type of head and neck cancer has been tailored being less is more kind of treatment, right? So the toxicity or the risk of secondary cancers with radioactive iodine, they generally happen when there is a repeated radioactive iodine, or what we call it as cumulative radioactive iodine dose. And at Fox Chase, we are very mindful of that. We very carefully watch what is the cumulative radioactive iodine dose, and we try not to go above a certain extent. More than 300 millicuries, what we use as a cutoff. Some institutions use it even higher doses of 600 millicuries. Have I seen a secondary malignancy, which is more of hematologic malignancy that we worry about after radioactive iodine? None. And that's coming back to the main focus being that we be very judicious in our dose and use it only when we think when the benefits outweighs the risk.
I do want to point out that there is data on a population level that demonstrates that in general, when patients have had exposure to radioactive iodine, there is an increased incidence of both leukemias and cancers that arise in salivary glands. So if you look at it on a population level, that has been reported. Although I don't, like I was saying, I don't think I've specifically seen one personally, but that doesn't mean that on a population level, we haven't seen an uptick in patients following reception of radioactive iodine.
The more worrying features for me when I give any radioactive iodine are the more common things like dry mouth, dry altered taste, or dry eyes. Those are the things which limit a patients from doing their activities of daily living. Pulmonary fibrosis is another big component what I watch for when patients are given repeated higher doses of radioactive iodine. So those are something, yes, more common, and we should all be more mindful before just giving radioactive iodine every year to patients with thyroid cancer.
And then we'll say the one, I guess, last question is how many head and neck trials are offered at Fox Chase? And I think we can all answer this question to a certain extent, but
I would say that's a Dr. Bauman question to answer.
I will say, I think what is a wonderful aspect of the clinical trials that we have at Fox Chase is that we really have trials that are available at every single stage and phase of disease. So we have clinical trials that are important in helping us understand when somebody is first diagnosed, what is the best treatment approach for their particular cancer. We also have clinical trials that look at cancer, at their cancers, if cancers are to come back and are and have failed the initial treatment, are there new and different treatment approaches that we can use? So we have several dozen trials that are available at all different aspects of cancer treatment that I think we are very proud to be participating in, and some of them we're running.
I just want to point out that for our audience that participation in a clinical trial doesn't mean your cancer is extra bad, that we don't know what to do. Clinical trials, all the treatments we do today, working as part of a team and making good decisions, are because 10, 15, 20 years ago, we didn't know what to do. We did studies, and now we know how to treat patients better. So when you get placed on a clinical trial, it's a really rich opportunity to really participate in the best available treatment for your particular cancer. And so it doesn't mean that your cancer is super bad or something that we need to, do something experimental. What it means is sometimes we have A and B that we know work super well, but we don't know which one might be better. And so a clinical trial allows us to be very organized about studying the question about whether A or B is better, so that in the future, a future patient can benefit from your treatment that you go through for your treatment. So I want to really emphasize that, because I think some patients get the idea that a clinical trial means my cancer is extra bad. And what it is really, all it means is that we're doing the best and latest treatment for you. We just don't know exactly which way to go. And by being organized, we can help you and future patients.
Thank you, everybody. So it is a few minutes after 7:30. So I just want to say thank you again so much for participating tonight, for asking these questions, for tuning in and to spending your evening with us. Thank you again for our exhibitors and our advocacy organizations for participating. And thank you in particular to our survivors who sent in pictures and words of encouragement. Thank you to my colleagues, Dr. Liu, Yao, Dr. Geary, Dr. Galloway, Leanne, Karen, Dr. Sharda, and Florence. And I will also note for those interested that our last Together Facing program for this spring at Fox Chase will be Together Facing Prostate Cancer, if you'd like to tune into that on May 12th. And you can check our website for more information about this. I truly hope that we'll be safely together in person soon. Good night and take care.